Good evening, everyone, and welcome to the last session of our 2019 Closer to a Cure community lecture series. This is a partnership between UCLA Health and the Leukemia and Lymphoma Society. So through this partnership, we've been traveling to different communities in Southern California to bring updates about blood cancer in your backyard. And all of the programs have been live streamed, as well as this one. And they are also archived, so you can still tune into the programs at your convenience if you've missed it. So tonight, we are very lucky to have Dr. Monica Mead, who's going to be speaking about diffuse large B-cell lymphoma and follicular lymphoma. And we also want to take a moment to recognize our special hosts for today, We Spark Cancer Support Community. We are here live with them, and I'm going to ask Marlene McGirt to just talk about We Spark for just a couple minutes.
Thank you very much. So nice to see everybody. I see some of our guests are here. We're happy to be here. I'm Marlene McGirt. I'm the Director of Development at We Spark Cancer Support Center here in Sherman Oaks, California. What we do, we're a cancer support center, and we alleviate the physical and the emotional effects of a cancer diagnosis and treatment. We do that through workshops and support groups and integrative services, healing modalities that help alleviate the anxiety, the uncertainty, and also we build a community of people going through the same thing. Our support groups are wonderful. We use it in our support groups are in especially for cancer patients is through the different phases of their cancer treatment and experience. We're all free of charge. We serve over 1,000 people a year. It's not just the cancer patients, it's also the caregiver and loved ones. When one person has cancer, everybody's affected. We are so privileged to be able to serve so many people since 2001. So thank you, and I wish you the best workshop. Thank you for being here.
All right, thank you so much, Marlene. For those of you who are joining us online, if you have any questions at all throughout this whole program, you can always put in your questions into the comment box, and we'll be able to answer them during the Q&A. So that will be later on in the program. So really quickly, I am going to talk about the Leukemia Lymphoma Society, all of the services that we provide, just to give everybody a brief overview. So the organization is focused on two things: having cures for blood cancers, leukemias, lymphomas, myelomas, myelodysplastic syndrome, and myeloproliferative neoplasms, as well as making sure that everybody has good access to health care. So we do that through different arms of the organization. We really focus on research is one big one. We pride ourselves in making sure that we work with everybody in the treatment ecosystem to make sure that that we are advancing in cures for blood cancers. We also do that through advocacy and working with public policy to ensure that the voice of blood cancer patients or cancer patients in general are heard. But we also do it through our free services for patients and caregivers. So I'm going to talk a little bit about the different free services that we have. First off, just so that everybody knows, we do have information specialists, and they're really the epicenter of everything that is patient and community outreach related. They will be able to answer your questions regarding disease treatment information as well as navigation. And they will also know about all of the different services that are available both nationally and locally with our organization and with other national organizations. They are master's level oncology nurses, social workers, and health educators who can really help with all of the different questions that you might have, whether it is, what questions should you ask your doctor, to what is the latest in the different treatments. With access to the information specialists, we do also have a clinical trial support center, and through there we have a team of nurses who can help really narrow down the different options that you have and help you, because it really is a different language when you go on clinicaltrials.gov. And we want to make sure that you know the different options that you have, and you can bring them to your doctor and talk about what you want to do. So we also have a nutrition consultation, and they can really help with any of your nutritional needs. It is one-on-one, and it is for all cancers, not just blood cancers. In addition, we do have a lot of education resources, everything from booklets to articles online to podcasts that you can listen to, and education programs like this one are available throughout Southern California. The next one, we have a program on CLL that's going to be in Ventura in November 16th. And we also have our upcoming blood cancer conference, which is a large conference where we have all of the thought leaders in blood cancer treatment who are there to talk about what's new and how you can be your best advocate. So in addition to the education, we also have peer-to-peer support, community support programs. You can talk to, depending on what you're looking for. I'm sorry, I need water. What you're looking for, there you can talk to somebody who is one-on-one with somebody who is a volunteer. If you are having a new diagnosis, you're having treatment, or you're a caregiver, they'll be able to share their experience with you. We do have support groups as well that you can talk about. I'm choking on my hold on. There's support groups as well. And then you can talk to people on a monthly basis. We also have LLS community where you can talk to people online and be able to share your wisdom as well. Lastly, we do also have financial support resources available. Everything from travel assistance if you're living here in Southern California, to copay assistance, urgent need, and patient aid. So all of those different things are available for patients and caregivers to take advantage of, and we really hope that you do. Lastly, we also have different ways that people can get involved in the community or to mobilize the mission. For example, we have Light the Night that's coming up November 9th, which is Saturday, which is a beautiful walk that everybody can attend and light the night with lanterns and join the community to celebrate and commemorate those who've been affected by cancer. So we really do hope that you get involved with the Leukemia Lymphoma Society and take advantage of all the resources that we have available. So now that we've given you an overview of the organization, I wanted to introduce our speaker. Again, if you are online and you have questions, please go ahead and put them in the Q&A. So without further ado, Dr. Monica Mead from UCLA Health will be talking about diffuse large B-cell lymphoma and follicular lymphoma. Please give her a warm welcome.
Hi, everyone. As she said, my name is Monica Mead. I'm a physician at UCLA. I'm part of the lymphoma program there, so I primarily see lymphomas. So excited to see so many of you guys out here tonight. I think it's really important to educate patients. I think it's a good idea for you guys to be involved in the decision-making for your health care, so I'm a big believer in helping educate patients. So I've done a lot of these Leukemia Lymphoma Society talks before, but this is my first one that's live streaming. So please feel free to also log on to their website because some of my other colleagues have talked about different topics that you might be interested in as well. So they've asked me to talk about diffuse large B-cell lymphoma and follicular lymphoma. This is a very broad topic. I could easily speak for hours about just diffuse large B-cell or just follicular lymphoma. So I hope that I've covered portions that are of interest to you guys. I have primarily focused on treatment, but we will touch base on staging and diagnosis and things like that as well. Next slide. Okay, so the outline of the talk. What are diffuse large B-cell lymphoma and follicular lymphoma? What are some common signs and symptoms? How do we make the diagnosis? How do we stage our patients? What are the frontline therapies? And like I said, I want to do a spotlight on recently approved drugs. What are the therapies for relapse disease? And excitingly, what are some of our emerging therapies? Next slide. So before we talk about what is abnormal, let's talk about what is normal and where lymphoma arises from. So pictured on the left is a very simplified representation of our immune system. All those green squiggly lines you see is our lymphatic system. That's basically the highway for all of our immune system cells. The immune system cells are known as lymphocytes. And so the lymphocyte is the cell in your body from which lymphoma arises from. All subtypes of lymphoma arise from a lymphocyte. And so you can see that the lymphatics, those green lines, are intimately involved with the bone marrow as well as the spleen. And that explains why some of you guys may have had to undergo bone marrow biopsies and things like that. Okay, next slide. So the American Cancer Society defines lymphoma as a cancer that starts in white blood cells called lymphocytes, which are part of the body's immune system. And Merriam-Webster's dictionary defines it as a usually malignant tumor of lymphoid tissue. And pictured in the lower right-hand corner, this is actually lymphoma underneath the microscope. So this is what we're seeing with some of the biopsy materials that we take that help us diagnose what's going on. Next slide. Non-Hodgkin's lymphoma classification. Before I dive into this, I do want to give one additional explanation. So under the umbrella of lymphoma, your first break is actually to determine if a lymphoma is Hodgkin's lymphoma or non-Hodgkin's lymphoma. Both diffuse large B-cell and follicular are non-Hodgkin's lymphoma, so we will not be discussing Hodgkin's lymphoma tonight. So after you identify if a lymphoma is Hodgkin's or non-Hodgkin's, under the non-Hodgkin's umbrella, it's further categorized into indolent, aggressive, and very aggressive. And this is loosely based on the way a lymphoma behaves. So the lymphomas listed in the indolent category are going to grow a little bit more slowly, behave a little more indolently, maybe not make a patient feel so sick. Whereas the lymphomas within the aggressive and very aggressive category tend to grow very rapidly, very quickly, and cause symptoms. Next slide. Oh, go back one more. So tonight we're going to be talking about one of the indolent lymphomas, follicular lymphoma, as well as one of the aggressives, diffuse large B-cell lymphoma. Okay, next slide. How common are diffuse large B-cell lymphoma and follicular lymphoma? So if you take a look at the picture, this is a pie chart of the frequency of all the various subtypes of non-Hodgkin's lymphoma. The bigger the piece of pie, the more common the lymphoma. If you take a look at the two largest pieces of the pie, those represent the lymphomas we're discussing tonight. So follicular lymphoma makes up around 22% of all non-Hodgkin's, and diffuse large B-cell makes up around 30% of all non-Hodgkin's. If you take a look at the citation down at the bottom, this data was released in 1998. So by medicine standards, this is very old data. However, I presented this old slide because these numbers still hold true today. Next slide. Yeah. This is one of the most common questions that I get from my patients. Why did I develop diffuse large B-cell lymphoma or follicular lymphoma? In my experience, a common misconception is that lymphomas are inherited. I get concerns from patients that if I have lymphoma, am I going to pass this lymphoma on to my children? And the answer for the majority of patients is no. This is not inherited. You're unlikely to pass any risk on to your children. The majority of patients get lymphoma due to a sporadic change in the DNA inside of those lymphocyte cells we talked about initially. There is a 1% familial predisposition, but that means the other 99% of patients with non-Hodgkin's lymphoma do not have a genetic predisposition. There are a subset of patients that get a lymphoma because they may have some type of an infection. The majority of the infections that can predispose a patient to lymphoma are generally viral. These include EBV, hepatitis C, HTLV1, and KSHV1. H. pylori is the only bacteria listed there. An immunodeficiency state can increase the risk of developing a lymphoma. You can have a congenital immunodeficiency state, meaning that you are born with some problem in your immune system. That may lead to a lymphoma. There are other acquired immunodeficiency states, including HIV/AIDS, and patients that need an organ transplant, a kidney transplant, heart transplant, etc. Those patients are put on immunosuppressant medication so that they don't reject their organ, and unfortunately, that puts them at an increased risk for developing a lymphoma on down the road. There are some autoimmune disorders that cause chronic inflammation in the body that increase one's risk for developing lymphoma. And there are also some environmental factors such as chemicals, chemotherapy for other prior cancers, or radiation for other prior cancers. I'm getting a lot of questions about what is the chemical that they're advertising? Yes, I'm getting a lot of questions about that. The jury is still out on that, so I don't have any scientific information about that particular topic. Next slide. Signs and symptoms of lymphoma. If you'll notice, I did not differentiate between follicular lymphoma and diffuse large B-cell lymphoma for signs and symptoms because there are a lot of overlap. And a patient does not need to have all of these symptoms listed here. Some have a few, some may have many. But the common ones include painless swollen lymph nodes that are pictured here on the right. You can see one in the neck and one behind the ear. Fever in the absence of an infection, fatigue, and I don't mean your everyday fatigue that a lot of us experience. I mean profound fatigue that makes it difficult to make it through your day and to do activities you could easily do 3 months ago. Night sweats, loss of appetite with associated weight loss. Rarely it can present as rash, bone pain if you have lymphoma involved in the bone marrow, a cough, abdominal pain, or chest pain. A lot of the symptoms are going to vary based on where the lymphoma is located. So if a patient has a lot of lymphoma involvement in the chest, that may cause a cough. If they have a lot of lymphoma involvement in the abdomen, that may cause abdominal pain. Next slide. Appropriate evaluation and staging for both diffuse large B-cell lymphoma and follicular lymphoma are very, very similar. So this slide is also lumped together. So all evaluation for a suspected non-Hodgkin's lymphoma starts off with a good history and physical exam. We also do lab work. I did not list the complete set of labs that I draw. You guys probably are aware of that. You've probably had several tubes of blood drawn. I just listed kind of the most basic ones because the entire list would take up the whole slide. But some of the primary things we look at are complete blood count, LDH, and I also check for the presence of circulating lymphoma cells in the blood. We do a PET CT or CT scans with IV contrast. More on that in a future slide. We also do a tissue biopsy. So the tissue biopsy is going to vary based on where the patient has suspected lymphoma. So you're going to biopsy whatever is the safest, most accessible lymph node. And then this last bullet point, I have a plus or minus beside it because not all patients need all of these procedures. The procedures that are listed in the final bulleted point are done on a symptom-based presentation. So if I see low blood counts, patients get a bone marrow biopsy. If they're having stomach pain, nausea, things like that, then they're going to get an endoscopy. If they're having any neurological symptoms, vision changes, headaches, then they're going to get a lumbar puncture with analysis of their CSF fluid. Next slide. So let's talk a little bit more about PET CT or CT scans with IV contrast. I'm taking a little time with this topic because you guys probably get several CT scans or several PET scans, and I want you to understand what the doctors are looking at whenever we take a look at these scans. Next slide. So on the left is a representative image of a PET CT, and on the right is a representative image of a CT scan. Increasingly, we are favoring PET CTs, particularly with diffuse large B-cell lymphoma. at least during the staging and the treatment phase. You may be getting CT scans for surveillance after the end of your treatment. But you can see the images are quite different. So the reason we favor PETs, by we, I mean lymphoma doctors, the reason we favor a PET CT at diagnosis and during treatment is because the PET CT gives us lots of good information. It gives us the location and size of lymph nodes, but then it also gives us the metabolic activity of lymphoma. And that's reflected by that brightness that you're seeing on that scan that is absent over here. So you can have treated lymphoma that still looks abnormal on a CT scan. But on a PET CT, it would not light up. It would not have that bright feature. So that's very important information for us to have. If you take a look at the right, that's a CT scan, and the little arrows are just pointing to an enlarged spleen. And also to orient you, these images are if a patient was lying on the bed, feet here, head here, and these are cross-sectional images. Next slide. The next most important thing we do is a tissue biopsy. It is very, very important to get adequate tissue, particularly for lymphoma. If you guys remember that slide that I showed you in the beginning that listed all those different subtypes of lymphoma, it can be very challenging for a pathologist to be able to differentiate between those different subtypes. So we really need to give our pathologist adequate tissues so they can do the best analysis possible, because I need to know your right diagnosis to be able to treat you appropriately. Next slide. So I go a little bit here into detail about the biopsy as well. I say, how do you diagnose diffuse large B-cell or follicular lymphoma? Tissue is the issue. So as I said, adequate sample of tissue. You generally do a biopsy of an enlarged lymph node, a mass, or the bone marrow. And we do all sorts, or the pathologists do all sorts of tests on this tissue. Morphology means they take a look. What does it look like under the microscope? Do the cells look funny or do they look normal? Immunophenotype. This is evaluated by stains, and an example is here on the right. So we have stains that bind to certain proteins on the surface of a cell. And lymphoma cells are going to have a different cell surface protein expression compared to a normal lymphocyte. So this helps differentiate between lymphoma versus not. We take a look using a test called flow cytometry, and then we also do a couple of different evaluations of the DNA inside the lymphoma cells. Next slide. So we stage patients commonly using the Lugano classification. There's another one that you may have heard of called the Ann Arbor classification. It's a little bit older. Lugano is more the way we're all leaning, and it's very easy to stage. So if you take a look here, we all have a diaphragm, a little thin muscular area here in the center of our abdomens that help us breathe. So stage 1 means that all of your lymphoma is on one side of the diaphragm, involving only one lymph node group. Stage 2, you're still on one side of the diaphragm, but you have involvement of 2 nodal groups. Stage 3, you have lymphoma on both sides of the diaphragm. And stage 4, lymphoma is on both sides of the diaphragm and involves extra nodal sites such as the liver, lungs, bone marrow. Next slide. So now we're going to transition over to treatment, which is where I want the focus of this talk to be, and we're doing fairly well on time. So this is the fun part of lymphoma, at least for the doctors, maybe not so much for the patients. But the reason I say it's the fun part is because lymphoma treatment has really evolved, and we have so many options to give you guys now. It's not just a one-size-fits-all approach for all different types of lymphoma and all different patients. I look at treatment as kind of having a toolbox filled with various tools that I can treat patients with, and I have to select what is the best tool for each individual patient. So some of the options are always, I look for an appropriate clinical trial for my patients. No matter what your particular lymphoma or what line of therapy, we have some really exciting, well-designed clinical trials that we're running out there. If there's not an appropriate clinical trial, we might be talking about chemoimmunotherapy, immunotherapy, small molecule inhibitors, to a lesser extent radiation, and some patients may undergo a stem cell transplant. Next slide. So I know this is a busy slide, but I want us to take a few moments here. It's one of my favorite pictures to kind of represent how broadly we treat lymphoma. So the blue guy in the center, this is a lymphoma cell. Within the lymphoma cell, you see a light blue circle. This is the nucleus. And if you reach back to your high school biology class, the nucleus is kind of the brain of the cell. It has the DNA packaged in it. And then you see the little rectangles on the surface. These are proteins that are expressed on the surface of a lymphoma cell. So all of these different areas of the cell allow us or provide us with opportunities to target treatment of lymphoma. So we are going to be talking about, in the upper left corner, the anti-CD20 monoclonal antibodies. So these are molecules that bind to the CD20 protein on a lymphoma cell and help cause cell death. We're also going to be talking about the kinase inhibitors. So kinase inhibitors are going to act at a pathway inside the lymphoma cell that's important for survival. We will be talking a little bit about the HDAC inhibitors. These function at the level of DNA, as do the alkylators. And alkylators, that's kind of a fancy word for chemotherapy. We won't be talking about BCL2 inhibitors. We'll be talking a bit about checkpoint inhibitors. This is the so-called immunotherapy. So there was a medication called Keytruda that got approved by the FDA to treat melanoma and lung cancer a few years ago. And it was on commercials all over the place. And every single patient that walked through my door asked, what about immunotherapy? What about immunotherapy? So this is the immunotherapy that has been on the TV so much. It plays a smaller role in lymphoma than it does in some other cancers, but still an important option for us. So we'll discuss that a little bit. And then also we'll be discussing CAR T. Someone in the audience shared with me that he actually just received CAR T therapy at UCLA a couple of weeks ago, and happy to say he looks really good tonight. Okay, next slide, please. So we're going to start off with treatment of diffuse large B-cell lymphoma. Now, I have not been dividing follicular lymphoma and DLBCL too much up to this point. They will be separated in the treatment section because these lymphomas are treated differently. So let's start off with diffuse large B-cell lymphoma. Now, if you recall, I said DLBCL was one of the more aggressive variants. So this is a lymphoma that you want to treat as soon as it is diagnosed. You will see in a subset of follicular lymphoma, we may not be talking about treatment up front. That will never be the case for diffuse large B-cell lymphoma. So for our early stage patients, meaning patients with stage 1 or 2, which, remember, lymphoma all on the same side of the diaphragm, if you have lymph nodes that are not too large, if they're less than 7.5 centimeters, then you'll be looking at a regimen of chemotherapy called R-CHOP for 3 cycles, with or without radiation to the sites of disease. Now, R-CHOP you're going to hear over and over again throughout my talk. Many in the audience may be familiar with this regimen, but just to tell you what it is, the R is Rituxan, which is the medication that binds to that CD20 protein I mentioned. And then the chemotherapies that are included are Cytoxan, doxorubicin, and vincristine. Don't ask me how the letters match up with the CHOP. And then the P is prednisone. So that's a steroid pill that's also very important for lymphoma treatment. So early stage disease, the takeaway from this slide is you may be able to get away with an abbreviated number of cycles of chemotherapy, only 3, whereas the more advanced stage patients, you cannot do only 3. Next slide. So now let's talk about diffuse large B-cell management for advanced stage patients. So this is a little bit busy, but I want you to just focus on the left half. So if you have a patient with advanced stage diffuse large B-cell lymphoma, around 90% of patients are going to be candidates for R-CHOP. Around 10% are not candidates, and the way you determine candidacy is how fit is the patient. You need to have a fair amount of reserve and to be fairly strong going into a regimen like R-CHOP. You know, if you're very elderly and frail and have lots of other medical conditions, then R-CHOP is not going to be the best option for you. But the majority of patients are candidates for R-CHOP. And R-CHOP results in cure in around 60% of patients. Okay, next slide. So diving into R-CHOP a little bit. So I wanted to review the data with you guys briefly that made R-CHOP the gold standard for treating diffuse large B-cell lymphoma. So It was based on a trial called the LNH 98.5 trial. This trial was published in 2002. That is ancient in terms of medicine. It still kind of blows my mind that I'm talking about a regimen from 2002 here in 2019. Numerous efforts have been made to improve upon the outcomes of R-CHOP, which we will discuss in a few future slides, but the short story is that R-CHOP still remains the gold standard, and it's based off of this old data. So in this trial, they enrolled 399 patients with diffuse large B-cell lymphoma. They treated half of them with CHOP and half of them with R-CHOP. R-CHOP resulted in a larger proportion of patients achieving a complete remission, and the addition of Rituxan did not add toxicity. That's what the R is. So boom, R-CHOP is our gold standard. There are some special scenarios, that 10% where I said R-CHOP is not the best idea, patients that are elderly, those with underlying cardiac disease, and patients with HIV. We'll discuss that a bit more in detail later as well. Next slide. Okay, so since 2002, what has the medical community done to try and make R-CHOP better? Well, we thought if R-CHOP works so well, maybe we can give more R-CHOP and that'll be better. Can we give higher doses? Can we give it an increased frequency or maybe more cycles? We tried an R-CHOP backbone and just adding a new drug to it. We tried a different Rituxan, so a different medication that binds that CD20 protein. We gave R-CHOP and we followed that up with some kind of maintenance medication. Next slide. What we learned from all of that is more is not always better. Next slide. So efforts at adding more chemotherapy. We tried 8 cycles, wasn't any better than the standard 6 that we give. We took a look and said dose dense, if we increase the doses, is it any better? It wasn't better than standard dosing. Giving it in an infusional manner, meaning dripping it in over 24 hours, that was no better than the standard administration. Doing a stem cell transplant in frontline treatment was no better than R-CHOP alone. We tried adding Velcade and ibrutinib, didn't help. We tried exchanging Rituxan for something called Gazyva or ofatumumab. Neither one of those were any better. We tried giving R-CHOP and following it up with just Rituxan or just a medication called lenalidomide. That didn't help either. Next slide. So let's move on to talk about the special scenarios, what I do for this subset of patients. Next slide. So for our elderly patients, you can give what we call, it's not a very scientific term, but it's essentially a dose reduction of R-CHOP. The efficacy with a dose-reduced R-CHOP is still quite good, but not as good as if you are able to receive full-dose R-CHOP. You can do a different type of chemotherapy, procarbazine or liposomal doxorubicin or gemcitabine. You have similar options for patients with underlying cardiac disease. And then for our HIV population, there is an infusional regimen called EPOCH that you are able to tailor the doses very nicely to prevent patients with HIV from getting into trouble with infections. Having said that, I always add on HIV treatment while I'm giving the chemotherapy, and I make sure these patients are on a lot of prophylactic antibiotics, antifungals, and antivirals. Next slide. So what we've discussed up to this point has been the treatment of diffuse large B-cell lymphoma initially. Well, what happens if that initial treatment does not work or if the lymphoma comes back? So if you have a patient with relapsed or refractory disease, the first thing I ask myself is this patient a candidate for a potential bone marrow transplant? For those of you not familiar with bone marrow transplant, we'll discuss the process in a few slides, so just keep that in the back of your mind. The reason a bone marrow transplant needs to be considered is if lymphoma comes back, you can get a patient back into remission with more chemotherapy. The problem is they rarely stay in remission if you just stop at more chemotherapy. You generally have to do an additional step to maintain that remission, and that additional step is a bone marrow transplant. So if I have a patient that I think is a good candidate for a transplant, meaning that they're fairly fit, don't have a lot of other medical problems, then what I'm going to do is I'm going to give them a second-line chemotherapy. And the second line, the regimen can vary from institution to institution. There's not one that's the best or the least toxic. So any of the regimens listed here are appropriate, although the MINE, nobody really uses that one. So you try second-line chemotherapy and you assess the patient for a response. If they went into remission with the second-line chemotherapy, that is the point when you move on to do the bone marrow transplant. So you need to have some degree of response. And at our institution, we rarely transplant anyone that has anything less than a complete remission. And so if you have a patient that has went into remission with second-line chemotherapy, that's when you move on to the bone marrow transplant. On this slide, it's referenced as high-dose therapy with stem cell support. Okay, next slide. So a word about this high-dose therapy with stem cell support. So I'm going to use this interchangeably with the phrase bone marrow transplant, even though I do not like the phrase bone marrow transplant. High-dose therapy with stem cell support is much more accurate. Bone marrow transplant ends up confusing patients. They think that they have to go to an OR and they have to get something transplanted and they're about to undergo, something painful. And our transplants are painful in their own right, but it's not because you're going to an operating room. Okay, next slide. So what is a stem cell transplant? So what a stem cell or a bone marrow transplant allows me to do is safely give high doses of chemotherapy that I otherwise would not be able to give. So the reason it works is because in a patient where the lymphoma has come back, you give chemo and they're back in remission, there are likely still lymphoma stem cells floating around somewhere in the body that are too few to be visualized on a PET CT scan. So all they need is a little bit of time to kind of find a niche and start growing and become yet another relapse. There were some studies done in the lab that demonstrated that if you could just increase the doses of chemotherapy, then those stem cells actually could not survive. Well, that's all well and good for the lymphoma cells, but the problem is a patient's healthy cells also couldn't survive. So what we do is we remove a patient's stem cells prior to giving them those high doses of chemotherapy, so that after the high doses of chemotherapy are administered, I can then infuse stem cells back into them to repopulate the bone marrow and to give them nice, healthy blood cells. So there's a graphic here showing how it's done. Bone marrow is removed or blood is drawn. Very rarely do patients need to go and have it withdrawn with the needle here. We normally do it from peripheral blood. So the stem cells are collected. Chemotherapy is given to the patient in high doses to hopefully eradicate any lymphoma stem cells that are remaining. And then the patient's stem cells are infused back into them, and we wait for those stem cells to find the bone marrow and to start growing and reproducing. So just a few points to drive home about the stem cell transplant. A patient must be in remission. Stem cells are derived from the patient. There's another transplant where you get stem cells from someone else, but we will not be covering that one today. This is the more common transplant used in lymphoma patients. And your bone marrow recovers in about 1.5 to 3 weeks. Adverse effects occur in around 3 to 7% of patients. I should have put the word serious adverse effects. Adverse effects, mild to moderate adverse effects occur in a lot of patients, but serious adverse effects occur, fortunately, in only 3 to 7% of patients. Now, I will give a little bit of a caveat because I see one of my patients out here in the audience who doesn't fall into this category, although he did have a stem cell transplant. So he had a type of diffuse large B-cell lymphoma called primary CNS lymphoma. That is when diffuse large B-cell lymphoma is only in the central nervous system, the brain, the orbit, etc. So those patients are treated more aggressively because that tends to be a more aggressive variant of the disease. So patients with primary CNS lymphoma get pretty rough chemotherapy initially, get them into remission, and then they do go on to get a stem cell transplant in first remission. We do not wait for those patients to potentially relapse. Okay, next slide. So going back to our flow diagram, so for patients that are eligible for a transplant, we do try the chemotherapy. So those that get the response and go on to a stem cell transplant, that's wonderful for them. But what about the group of patients that don't respond to second-line chemotherapy? What if the lymphoma only shrinks a little bit, or what if it grows straight through the second-line chemotherapy? Had I been given this talk to you guys a year and a half, 2 years ago, I would be saying clinical trial only. But now I can say clinical trial or CAR T cells. So you guys may have heard about CAR T therapy. We've had 2 different CAR T products FDA approved within the last year and a half to treat lymphoma that has progressed through 2 lines of therapy. This is a really exciting new option that we have to give our patients that are in a particularly tough spot, because as you can imagine, lymphoma that has failed R-CHOP as well as one of these regimens can be particularly difficult to treat. Next slide. So what is CAR T? CAR T stands for chimeric antigen receptor T cell therapy. So if you take a look at the picture on top, you have a T cell is another immune system cell. It's kind of like our soldiers, our fighter immune system cells. So you have a normal T cell on the left, and if you look at the graphic representation of the CAR T on the right, you see the difference are those little green things that are on the surface. So those little green things are the receptor that is mentioned in the name. This receptor allows the CAR T cell to recognize a lymphoma cell, bind to it, and destroy it. So the process for CAR T is pictured down below. T cells are collected from the patient. Again, it's through just a peripheral vein. Those cells are sent to a lab to be engineered to become these super T cells. They're shipped back to UCLA. You are admitted to 6 East in our hospital, and the cells are infused. Okay, next slide. So this is a graphic representation of how the T cells do their job. So the white cell on the left is a CAR T cell, and the pink cell on the right is a lymphoma cell. So you can see the CAR T binding to the lymphoma cell, and when that happens, a cascade of events occur, and the CAR T releases these cytotoxic molecules, pictured as those little gold guys, that go over and kill the lymphoma cell. So it's re-engineering your own immune system to get rid of the lymphoma. Next slide. Again, getting back to me wanting to focus on newer types of things. This is data that is just hot off the presses, 2019. So this is the longest follow-up of the initial clinical trial that was done to get FDA approval for one of the CAR T products. And I'm happy to say UCLA participated in this clinical trial. We put several patients on this trial. So we started getting familiar with CAR T long before it was FDA approved. So what you see in the graph here is the duration of response of patients with CAR T. So our x-axis is number of months, and then the y-axis is the percentage of patients that have responded. So at month 0, you have a 100% response rate, and over the next few months, unfortunately, you see that graph decline. That means some of the patients are losing their response, and the lymphoma is starting to grow again. However, as the months get longer and longer, you can see this curve starts to flatten out. So that means if you continue to maintain your response over several months, the likelihood that you will lose your response becomes less. Okay, next slide. So what do we do for the patients who have relapsed disease but maybe aren't strong enough for transplant? Okay, next slide. So there's all sorts of things that we can do. And I should say if they're not strong enough for transplant or CAR T. So some other options that we have is a chemotherapy called bendamustine combined with Rituxan, with or without a new drug called polatuzumab. You could give a different type of chemotherapy. You can give one of our small molecule inhibitors called ibrutinib. We'll discuss that in a little bit. Another pill, lenalidomide, or a very interesting molecule, brentuximab. So I have bendamustine and Rituxan with or without polatuzumab highlighted here because this is one of our newer FDA approvals for diffuse large B-cell lymphoma. Next slide. So this is data from 2018. So what this trial did is they took patients with relapsed diffuse large B-cell lymphoma and follicular lymphoma, Half of them got bendamustine and Rituxan, and the other half got bendamustine and Rituxan with polatuzumab. And the results showed that polatuzumab improved outcomes in the diffuse large B-cell patients, but not in the follicular lymphoma patients. So the FDA approval for this drug is only for diffuse large B-cell. Next slide. So this is the raw data that the trial generated. This was, like I said, published in 2018. Next slide. I want to call your attention to these outcomes here. So the columns on our right are the diffuse large B-cell lymphoma patients separated into those that received polatuzumab and those that didn't. And you can see down here the outcomes favored the arm with polatuzumab. Next slide. So now we're going to switch gears to follicular lymphoma. I want us to kind of walk through this algorithm here. It lays nice groundwork. So the management of follicular lymphoma is also stage dependent in a similar way as diffuse large B-cell lymphoma. So if you have a patient that's newly diagnosed with follicular lymphoma and has never received treatment, the first thing you need to do is assess their extent of disease. Do they have limited stage disease, meaning just involvement of a few lymph node groups, or do they have more advanced stage disease? So let's talk about the limited stage first. So if you only have a small amount of follicular lymphoma, just a few lymph node groups involved, you may not need very aggressive treatment. You might be able to get away with just having the lymph node area radiated. Or you may do nothing and just observe the lymph node. Patients that have low disease burden with just a few lymph nodes involved can safely be observed for many, many years in a lot of instances. You could just give rituximab alone. The combination with chemotherapy is rare in early stage disease. Most lymphoma doctors are not going to recommend chemotherapy for someone that just has a low-grade lymphoma involving a few lymph node areas. Now, looking more at our advanced stage disease patients, these patients are treated differently. So once you determine a patient has advanced stage disease, you then need to ask yourself, do they have a low tumor burden or a high tumor burden? And next slide. This is how we determine low or high tumor burden. There's a couple of different criteria. The one that I tend to use the most frequently is called the Guelph criteria. They include symptomatic lymph nodes, meaning do you have a lymph node that's pressing on something that is making you uncomfortable? Do you have a lymph node in a visible site that has gotten pretty large and is maybe making you feel self-conscious? B symptoms. These include drenching night sweats, recurrent fevers, unintentional weight loss, profound fatigue, low blood counts, or if the lymphoma appears to be growing very quickly. These are all criteria meaning that a patient has a high tumor burden. So you can still have advanced stage disease, meaning you can still have follicular lymphoma above and below the diaphragm, but not satisfy any of these Guelph criteria. And even though you have quote-unquote advanced stage disease, you still have a low tumor burden. So if you have a low tumor burden, a lot of these patients they just undergo clinical observation. And a lot of times that is a tough sell for me with my follicular lymphoma patients. They say, I have a cancer and you don't want to treat me. I want to see another doctor. But this is actually very appropriate management for those patients. The reason this is appropriate is there have been a lot of studies looking into does early therapy or deferred therapy benefit the patients in this low tumor burden group. The short of it is that early therapy does shrink the follicular lymphoma, and that lymphoma may stay very small or even invisible for many years, compared to a deferred therapy patient where their lymphoma just kind of sits there and actually might grow a little bit. However, these details did not translate into improved survival for patients that received immediate treatment. What it did translate into is that they had more toxicities. So it does not adversely affect outcomes if you want to do surveillance for a patient with low tumor burden. Now, I have had patients where I explain this to them and they say, I don't care about any of that. The fact that I have lymphoma in my body is really, it's psychologically troubling to me. For those patients, I think single agent rituximab is a great option because it shrinks the lymphoma, you're treating the lymphoma, and it's not very toxic. Now, our high tumor burden patients, that is a different story. So if I have a patient that comes in with any of those Guelph criteria that's listed, it would be inappropriate just to say, let's just watch you and see what happens. Those patients you should treat. You can treat them with chemoimmunotherapy, in other words, something like R-CHOP, although that's not my preferred regimen, that's just an example. There's some data to suggest you can treat them with Rituxan plus lenalidomide. This recommendation is still evolving. I do not reach for this front line yet. In the rare instance, you might use single agent Rituxan for these folks. Next slide. So management of advanced stage follicular, I have brought back our picture here that we showed in the beginning. So low tumor burden, as I said, you can safely observe these patients. Observation doesn't mean sayonara, you don't see your oncologist again. It means that you come and see your oncologist every 3 months, history and physical every 3 months. I generally back off as the years tick by and transition to every 6 months at some point, assuming the patient is staying stable. So you do this for up to 5 years and then annually. You do CT scans no more than every 6 months for 2 years and then no more than annually. I see a lot of patients getting very frequent CT scans in some of my referrals, but these are the guidelines. For high tumor burden, single agent Rituxan, I don't commonly do that. More commonly, I'm going to combine a Rituxan-like medicine with a chemotherapy. Those regimens are abbreviated there. These are all acceptable, BO, BR, CHOP, or CBP. You could do a quote-unquote chemo-free regimen, this lenalidomide plus Rituxan. And for elderly, you make some modifications. BO and the lenalidomide plus R are highlighted because these are some of the newer datas. Next slide. Ooh, we're going to have to wrap it up real quick so you guys can ask some questions. So the gallium study aimed to answer the question, if you give bendamustine to follicular lymphoma patients, is it better to combine it with rituximab or a different, newer rituximab called obinutuzumab? The outcomes of this study are a little bit difficult to explain to patients. In terms of overall survival, both regimens did the same. However, the obinutuzumab arm kept patients in remission longer, but at the cost of toxicity. So this is a discussion I have with my patients. If you prioritize remaining in remission as long as possible and are willing to accept the increased toxicity, then BO may be the regimen for you. If you prioritize less toxicity, but still a very effective regimen, then I generally still prefer BR. Okay, next slide. Next slide. And so this is the lenalidomide and Rituxan. So this is the chemotherapy-free regimen. So this was published in the Annals of Oncology in 2017 and created a little bit of buzz for follicular lymphoma because it looked like the overall response rates were so high and you were getting these really great response rates but not having to give patients chemotherapy, which is always an attractive option. So this regimen has been looked at in 2 different studies. For the sake of time, we'll just look at the more recent one, the second bullet point, the Alliance study. So the Alliance study gave this regimen to a group of patients with advanced stage follicular lymphoma. The overall response rate was very high, 95%. The majority of those responses were complete responses, and it looks like overall the outcomes of this regimen are going to be very good. However, follow-up for this regimen is still not very long. There's much more follow-up for the chemoimmunotherapy arms, and for younger, fitter patients, I generally prefer that, at least for now. I might be saying something different in a couple of years. Okay, next slide. So management for relapsed follicular lymphoma, maybe this will be our last slide so that we can ask some questions. When I think about management one important thing I should say about follicular lymphoma is managing relapse disease is very common because follicular lymphoma is considered incurable, highly treatable, but incurable. So the majority of patients will have a relapse at some point over their disease course. The first thing I ask myself is this an early or a late relapse? Did they receive bendamustine and Rituxan 6 months ago and now the lymphoma is growing again? Or did they receive treatment 4 or 5 years ago and now the lymphoma is growing? For my patients that relapse early, they are treated more aggressively, and we may be incorporating a stem cell transplant into their treatment. For patients that relapse later in their disease course, we still have a lot more gentler options that we can use for these patients, and you can see all of them listed there. Next slide. Next slide. So duvelisib was actually the last thing I was going to discuss, and I don't think it's interesting enough to kind of step into our question section. So I will stop here and open it up for questions. Oh, and I also told my husband I would give him a shout out. He's watching me online.
Superstar.
Yes.
You said late relapse.
Mhm.
Can you define the time of late
24 months.
24 months?
Hmm.
Okay.
Yes.
I just had CAR T cell.
Yeah.
My 90-day scan is next week,
Hmm.
so I've been through like a lot of treatments you discussed.
Yeah.
I did REPOC. I didn't do R-CHOP.
Hmm.
And I did a auto stem cell already, and then now
Mm.
CAR T cell. But I've been having a lot of like skin issues after CAR T cell. Do you see that like I know it's still kind of a new therapy, but
So if you're 90 days out, I have not been seeing a lot of skin issues. The primary toxicity I'm seeing around the 90-day mark is we may still be seeing patients with low blood counts. I don't know if your blood counts have went low, but that's fairly common, and I may have to give patients Neupogen support. I haven't been seeing a lot of skin issues. Certainly skin issues can be seen with some of the transplants that we do, but CAR T generally not. However, rashes are so common with so many of the things that we do, it's certainly possible. I would suggest if it's persistent, a biopsy by dermatology would be very helpful. Did you get CAR T at our institution?
no, City of Hope.
Okay.
Yeah.
Somebody else? Yes.
For the follicular lymphoma, when you said it was the not aggressive tumor,
Uh-huh.
but you're diagnosed at stage 4,
Mm-hmm.
and you had the option of just doing the watch and wait, or
Mhm.
the maintenance, the R, I forgot what it was called.
Rituxan? Uh-huh. Yes.
How do you determine, is that still considered a trial situation, or has that been approved as a treatment?
Yeah, so all of this is a like standard of care stuff. This was not trial.
Because it was not ever discussed as an option where I go, and I'm
Yeah.
wondering if it was.
It's tough for me to comment without kind of knowing your whole history, but this is all fairly standard stuff. Yeah.
If we can have the questions repeated just for
yes.
the individuals online.
Yes. Yes.
Yes, so you mentioned about taking a person's own stem cells.
Hmm?
What is there to prevent you taking a cancerous stem cell out and then putting that back in to later grow?
So the question is, if you are undergoing an auto stem cell transplant and you are collecting the patient's stem cells, what's to say the stem cells are not contaminated with a lymphoma cell? This is an excellent question. There is a small theoretical risk that could happen. However, the stem cells are collected after the patient has already had their second line treatment and is back into a remission. So you were collecting at the time of remission, not during the time of active disease. Yes.
I've had, I had a very marginal B cell
Mm-hmm.
a number of years ago, and I noticed Rituxan was utilized, and it's still being utilized.
Yep.
Can you elaborate on what's so magical about that?
So the question is, she had another type of non-Hodgkin's lymphoma in the past called marginal zone lymphoma that was treated with Rituxan, and why is Rituxan so magical? Magical is actually not too heavy of a word. The lymphoma community, when Rituxan kind of came onto the scene, did feel like this medication was magical because not only was it not only was it improving outcomes in diffuse large B-cell lymphoma, it was working for marginal zone. It works for follicular, and it doesn't just work in the sense that it shrinks the lymphoma. It's actually improving overall survival in all of these lymph nodes, which this is our benchmark for approving a therapy as an improvement in overall survival. So the magic behind Rituxan is I'm sure there are several things that contribute to it, but one of the nice things about it is it targets that protein that's on the cell surface of the vast majority of B-cell non-Hodgkin's lymphomas. I didn't go into too much detail. There's actually T-cell non-Hodgkin's lymphomas as well, but that was beyond the scope of this talk. We just discussed B cells tonight. Greater than 95% express this CD20 marker. So Rituxan is effective in any type of lymphoma that's going to express that CD20 molecule. So it's binding directly to the lymphoma cell, and it results in cell kill in two different mechanisms. It also helps your own immune system get activated to help kill off the lymphoma cells. So that's the main reason why it's so effective and why it's used so ubiquitously.
How long does the Rituxan last in the body?
So that's a really good question. So the Rituxan half-life, if I recall correctly, is around 25-30 days. Don't quote me on that. I'd have to double check that one. But what I can tell you is one of the potential side effects of Rituxan can be fairly long-lasting. So one of the side effects is it can decrease the amount of immune globulins in your body. Immune globulins are immune proteins. And so normal B cells produce these immune globulins, and normal B cells also express the CD20. So Rituxan can decrease the normal B cells, and therefore you have lower amounts of immune system protein. When they started looking at Rituxan in the lab before they brought it into the clinic, there was a lot of concern that because of this, it was going to put patients at risk for having a lot of serious infections. And fortunately, that is not what we saw at all. Even though there is some degree of suppression of the immune system proteins, patients stay on maintenance Rituxan for years and still don't have much of an increased risk in infection. Oh, I forgot to repeat. Okay, yeah.
If there's no more questions, I think we can wrap up.
Okay.
Thank you.
Yes. Thank you so much, Dr. Mead. And thank you, everybody, for joining us online and for joining us here as well. Have a great night.
Thank you.
For everybody who's, I can use this here. For everybody who's here, if you can fill out your evaluations, that would be wonderful. And we can leave them at the door. But thank you so much for coming out.
So thank you so much. I've got to rush.
I know.
Nice to see you.
Good to see you, too. I think so. Oh, I have something for you. Hold on.
Oh, okay.
You're such a good sport. This is quacking the